Hello, everybody, and welcome to our PrecisCa tumor board on multiple myeloma. Very excited about these cases and our panel. I'm Dan Pollier from the University of Colorado, and I'm joined by a really great group of colleagues here today to discuss these cases. And so each of us is going to introduce ourselves, starting with Dr. David Schuster.
Hi, I'm David Schuster. I am a radiologist and nuclear medicine physician from Emory University.
Hi, I'm Dr. Peter Forsberg. I'm a medical oncologist with a specialty in multiple myeloma at the University of Colorado.
My name is IgA. I'm an associate professor at the Emory University Winship Cancer Institute. I specialize in multiple myeloma.
This is a 60-year-old female with a history of IgA Kappa multiple myeloma, now relapsed 3 years after autologous stem cell transplant while on maintenance bortezomib. And the question is, would a repeat autologous stem cell transplant be indicated in the setting of relapsed disease 3 years after the initial autologous stem cell transplant? So Dr. Forsberg, maybe let me first ask you, before we get to the meat of that question, what is a good interval between a transplant and a relapse? How many months or years are you satisfied with? Is there an answer to that question?
Well, I think, Dr. Nuka mentioned a second ago, something like, 36 months, I think that, in terms of remission post-transplant, there are a couple of things that we expect to impact it, including maintenance. In a patient who uses continuous maintenance therapy, our hope would be to see something in the at least greater than 2 year type window. I think what we're hoping for is substantially longer than that. This would be a pretty average amount of time. Something in the 3 to 4 year range, is something that would be, it's less than the, than the medians that groups have published on, sort of larger bodies of data. But I think it would be within the realm of an expected amount of time potentially to be in remission post-transplant. Maybe not optimal, but not, sort of within the range of normal. Not necessarily predisposing to high risk, future course. So I think it's relatively standard, if not ideal.
Got it. Thank you. And Dr. Nuka, can you help us with this specific question? It's been 3 years, patients relapsed, presumably healthy. Would you do a second autologous transplant?
Great. So have I done second transplants in the past? Absolutely. So before we decide on offering a second transplant, I always question myself, what is the benefit that I'm getting from a second transplant? So the prior data that we have in a situation like this shows that you get half the benefit from a first transplant. So if I'm happy with that 1.5 year, if I don't have any other regimen that can give me that 1.5 year, this is what I would be offering. But if I have other agents that I'm expecting much more benefit than a transplant, I'll be probably steering towards them. A small caveat in this patient's case, she's a 60-year-old woman, received maintenance bortezomib. She's a young lady. Here, there is what she got in terms of the maintenance was probably expected for what you expect from a bortezomib maintenance. But the best data that we have existing out there is all for the maintenance lenalidomide. Not clearly knowing why she was not on lenalidomide bortezomib makes me a little unclear to put this out. But if we're offering a second transplant and putting her on len maintenance afterwards, that's not an unreasonable approach.
Great. Okay. So I think to summarize this case, patient had a good outcome to a transplant. It is not unreasonable to think of a second transplant. One must just be very clear about what the expectations for outcomes would be with that second transplant, and to weigh that against the risks and benefits of other therapies that we have available at our disposal, which, as we've discussed, are many.